He completed his residency in diagnostic radiology and fellowship in interventional and cardiovascular radiology at UCLA. He joined Eisenhower in 2001 after completing his training and has served as president of Eisenhower Radiology Medical Group since 2006. He has also held key leadership roles, including chairman of the Department of Radiology at Eisenhower Health and membership in the hospital's Medical Executive Committee. Additionally, he is a board member and managing partner of Eisenhower Imaging Center, which operates multiple facilities across the Coachella Valley. Please join me in welcoming Dr. Mehran Elly.
Well, hi everyone. Happy afternoon. Hopefully I won't put you to sleep. I can't believe it's been 24 years. It just feels like yesterday. I had a lot more hair and a lot more energy, but it's been great. So disclosures, the only thing is I'm a managing partner of the Eisenhower Imaging Centers. Other than that, no financial disclosures for anybody that has to do with this talk. Today we're going to talk about basics of CT imaging, that's computer tomography. We're going to talk about the existing imaging technologies and the limitations that they have. And then we're going to get to what's called photon counting CT. That's the new form of CT that we at Eisenhower Imaging Center were the first place to have it west of Colorado. It was just FDA approved, we think, and everything else shows that it's a quantum leap ahead because the existing CT technology has reached the limit. So now we have to go to another different level. We're going to talk about the clinical applications, basically having to do with anatomic evaluation of the heart. Heart has always been very difficult to look at. First of all, it's small, it moves, and it's in a tough spot. We want to then, aside from looking at the structure, talk about plaque analysis. That's basically what cardiovascular disease is, right? So if you don't have a structural abnormality, the next thing that gets most of us is the plaque and the atherosclerotic disease. And then it's great to evaluate it, but who needs to have intervention? And that's a physiologic evaluation that in the past was only done by having a cardiac cath. When you go to the interventional cardiology suite, you get a puncture in your artery, they go in the coronary artery, they put a catheter, they take pictures. If it looks like it's narrow, they have a smaller catheter they put in, and they measure pressure before the narrowing and after the narrowing, and we're going to get into that a little bit more, and to see if it's a significant drop that would warrant intervention. During my residency and fellowship at UCLA, we were on the forefront of CT imaging and CT angiography. And we had a ton of challenges, right? Again, it's the same thing. It's like taking a picture, and for those of you who take pictures of a small bird that is flying really fast, it always just seemed like it was not going to happen. Finally, in 2005, Time magazine came out and said, look, we got it. We're going to actually be able to look at somebody's heart from the time that they're expected to have any disease and see how they're progressing, whether they have the disease and who we need to intervene on. Well, in 2005, it was great. That was a great picture, but it only really worked up to just a very recent past for patients who had a low BMI, meaning that they were skinny, and they had very low heart rate. That means that they were athletes, because those are the things that we could see well with X-ray, and the heart was beating slow enough so that we could take a look at it. And not only beat slow enough, heartbeat of 50, 60, 65, but it also has to be regular because we have to take the image in multiple locations. Otherwise, you're going to get zigzag. So it was a quiet time. But before we get to this, and I wouldn't be here if I didn't, and everybody else didn't think that we're there. So let's talk about what a CT is. Basics of any CT is an X-ray tube, just like when you go and get an X-ray, that's up on top. And then there's a patient or subject, and the X-ray is shot. It goes through the patient, and then there's somebody out here looking at it, right? How do we go from X-ray to a CT? And how do we go to better CTs? Single slice is when I started my residency, used to take 5 minutes to get a CT of the head. Then we went to bigger ones and bigger ones. Now we can get a CT of your entire body with you on a table during the time that they actually take the pictures, maybe about 5 seconds. So how do we get there? So let's first talk about how the X-ray is generated. X-ray is electrons moving really fast. And then as they're moving really fast in the space, they hit a stop. And that stop, they release their energy in the form of photon. That's electromagnetic radiation or ionizing radiation. How do we do that? Well, it's just like a light bulb that you have at your home, a little bit different, more expensive. That's an X-ray tube. And they turn on electricity through this. So it becomes rich in electrons in the vicinity of where it's going through the coil. And shortly thereafter, they turn on an anode, positive charge on this side. Negative electrons are attracted towards the positive very fast. And when they hit it, they produce the radiation. Well, that's great. Where do we go from here? There is the X-ray tube. I think everybody here has had X-rays, right? You're sitting on the table. The X-ray is produced. The X-ray goes through the person, and depending on what part of you it's going through, it's going to interact differently. If you have parts that are lungs, there's not much of interaction. Most of the X-ray will get through and leave a different imprint as compared to the bones. And that's why we can see a broken bone or soft tissue disruption. Now, an X-ray machine is literally the same thing as when you go have a CAT scan or you go to the cath lab and have an angiogram done. Basically, the X-ray, after going through the patient, it goes into what we call a detector. The detector is typically a material that is crystal. And that crystal, when it gets the radiation, it produces light, right? As it produces light, well, we have to somehow turn that light into an electrical signal. It goes into what we call a photodiode. That photodiode takes light and it converts it into electricity, the opposite of what you see coming out of a lamp. Now, light is very different as compared with X-ray. X-ray has high energy and travels in straight line. Light is a little different. It's like a drunken person. So it gets there, but it also goes this way and it goes that way. That's why you can turn on a light and everybody here in this room can see it. It may be dim, but you could see it. So what we have to do is we have to have these collimations, right? If you don't have the collimations, a light that's produced here can end up here and you can't take a picture of it, right? Because the picture tells you what it is sitting in front of it or sitting in the back of it. So those are the basic parts of an X-ray. So that's a chest X-ray. Now, how do we go from a chest X-ray into a CT scan? I'm sure everybody here has had a CT scan. My wife sitting over there has had numerous CT scans. Well, it's the same thing, but if you could just imagine taking that X-ray tube and going through around the patient in numerous projections and taking all of those and then giving it to a computer and having the computer go back and look and say, take a look at the X-ray coming through the patient from all these projections, and then tell me how that translates into what it went through and make a three-dimensional picture of it. Sounds a lot easier than it is, although it sounds complicated. So believe it or not, so X-ray started maybe like late 1900s is when we actually discovered that we can take X-rays. It took another 40 years or so to get the mathematics behind how you go and getting those projections and translate it mathematically to give you a picture that a radiologist or a cardiologist or anybody else can take a look at. And then after that, the first CT was not actually available until 1970. So that was a huge thing. Now we can actually see X-ray. We can see different parts through different parts of an X-ray in different projections, and we can go up and down. When the CT was provided, initially was a single slice. You put a patient in, and instead of just taking a picture from top to bottom, you're going to take a picture. And as you're taking a picture, this radiation is going on, and the detector and the X-ray tube are keeping the same orientation, and it's rotating around the patient. That sound that you hear, it's that gantry turning, and it's turning them both together. Then we figured out that, you know what, we can actually do better if instead of having a single row of detector, we can have multiple rows of detector. So we can take larger cuts and then get through the patient faster. And then it took a little bit longer than that for us to realize that we can actually get this X-ray tube and row of detectors to go fast enough that we could get the patient to go through this with the table moving continuously. This is how you feel when you're sitting on an X-ray, on a CT machine, and that's called spiral CT. Modern CT scanners, when you sit inside the CT scanner, it should not give you comfort that you have heavy tubes sitting in the bottom and heavy tubes sitting up on top, and it's rotating at about 4 rotations per second. Very, very fast. As it's rotating, 1,000 projections of X-ray are going through you, and they're detected by a detector. And each projection takes about 250,000 nanoseconds. So we make it like that so that when you hear it, you think that it's actually a big number. So that is, if you take a second and you divide it into 10,000 divisions, it becomes 2.5 of those divisions. That is extremely fast. So a regular detector is that ceramic or the crystal. And as the X-ray goes through, that's the crystal. You have a glue that hooks it up together with a photodiode. And we have all of these columns. The thickness of this column is about the same. Is to keep the light from here, patient is laying up on top, keep the light from here, not to go here, just to go here. It can only hit this part, right? And that collimation becomes an issue, as you'll see. As it's coming through, it hits, the photodiode takes that light and sends it over and makes an electrical signal. And that electrical signal is then converted into what you see as the picture. So 30,000 projections coming in 250,000 nanoseconds. It is way too fast. Even the fastest detectors we have now, they cannot measure. This is up to the new technology. They could not look at those photons one at a time. So what do? We've been looking at them as an average. We would just take the whole thing and we just see one lump sum in that area that we call the pixel that you're looking at. Our current studies, we have limitation in giving you the best resolution because the pixels are large. So that is called the spatial resolution. There's only so thin that we can become because those collimators keep the light from going from here to over there. They have a final width. And if that you put too many of them next to each other to make the pixels smaller, well, they end up occupying the entire space. So you don't have a place to actually detect. So there is an upsize of how many pixels or how high your resolution is going to be. We also have another problem. The other problem that we have is this process takes the photons, converts it to light, and then the light to electricity. And that is a slow process. Anything that has to do with light, turning off and turning on so you can do it again and again and again, it's a lot slower. So that gives you what's called the temporal resolution. That means that if it works great for a particle or a person that's sitting there not moving, but for any of you who've taken pictures with your iPhones or the professional photographers, you know that if somebody is moving, if you want to take a picture of them that's not blurry, you need to either have them stop moving or you have to have a camera with a very fast shutter. That means that you could take a picture before it has a chance to move a millimeter. Otherwise, it becomes blurry. So the limiting factor is what we were talking about. It's the fact that we have to have these collimators to keep the light from getting scattered. And we have limitations of how much megapixels we can have in that picture because every one of those has to be divided by these collimations because of the nature of the light going in. Up to before, our highest resolution with regular CT scanners was 0.6 millimeters. Now that's not bad. That is pretty good. But in order to see things in the heart or other parts of the body, you got to do a heck of a lot better than that. So the new technology, we can actually get to 0.2 millimeters in thickness. Now, for me, it's hard to see a millimeter without my contacts and additional glass and a loop. 0.2 millimeters is very, very small. And I'm going to get through this part very quickly, and then you will see what are the things that we could actually see. Now, again, it's the same thing, though. This is the old technology. That's the new technology. You don't have any of this anymore. So the X-ray comes in and it says, I'm going to have a new detector. And that detector, what if I have a detector that doesn't need to convert photon into light, and it could just be directly detected? Well, that's the new technology. It's to bypass this light conversion. It's this light conversion that really disables us from doing this. And up to a few years ago, we had no technology that could do this. Again, this is explaining when you have a slow shutter, you'll get a blurry picture. But if you can take the picture fast enough, meaning that you get away from rate limiting step, and if you can just go from X-ray to electrical, that would be great. So that was the trick that we just could not do up to this point. So this is the heart when we were looking at it in 2005. You could see it. And if you go look at the CTs that you've had in the past, it's very hard to see the heart. You could see the heart, but you really can't see, that's the newer CTs. You really can't see details in it, right? It's great, it's there. I know it's there because I can see it much better than I did before. But what if you had a shutter that was fast enough that could take a picture of the heart before the next beat in that few fractions of a second that it's not doing that, you can actually take a picture of it. And its resolution is high enough that you could see very small detail. This first scanner was made by Siemens. So the detector from being a ceramic is now changed into a semiconductor. Now, everybody here knows that semiconductors are what you have in your phones, in your computers. So by nature, they are very, very fast. But the trick about the semiconductor is that it takes photon, it takes X-ray, and it converts it into an electrical signal. It works the opposite of what most semiconductors work. That's called a photon counting CT, because unlike any other CT or unlike any other detector, it is not detecting light, it's detecting the photons. And it's not averaging those lights. It's literally looking at every photon. It is that fast. So I'm going to skip through all of this. So this is the first photon counting CT here at Eisenhower, and this is the first one that was west of Colorado installed. We installed it just several months ago. This is Dr. Madavi, one of our physicians. He's on it, patient 0. And I can tell you with a lot of pride that we went a week ahead of UCLA. So I was able to send this picture and the first pictures of our CT angiogram to the guy who trained me at UCLA, the chair. He has not responded, but that's not unusual. I'm sure next time I see him, I'll get a few nice words. But they have it at Stanford Children's. They have it at UC Irvine. That went up. All of those went up after us. The only other place that has it now, I believe, is UC San Diego. They have installed it. They're probably going to be a year out before they have it. It's just very slow. It takes a lot to get it going, and it takes a lot of permits, and it is extremely expensive. The cost of the scanner is, just to give you an idea, is $2.4 million just for the scanner. Now, versus the best CT scanner that I buy for the imaging centers, our bread and butter, about $500,000. So it costs about 5 times more. The cost of maintenance of the scanner, I buy the full coverage for that for about maybe $60,000 to $70,000 per year because they're not cheap. The coverage cost for this is $350,000 a year. Once you see the pictures, you'll know why. Um, And it takes about $1 million of TIs of making the room ready. The amount of power that the scanner takes is 4 times of a regular CT scanner. So we literally had to run additional power that could supply 4 scanners into this room. So it was a big task, and we were able to do it. So these are all lots of technicals, but I'm going to go through them real fast. So we have much smaller pixels, so we can take much higher resolution pictures. We actually have about 9-fold increase in resolution. Does anybody know what this is? Okay, so that's the ear, right? And these are the ossicles. And if you look at the ossicles, this is the tympanic membrane outside, and then you have 3 ossicles. And then this is the oval window that goes back and forth, translating this sound that comes in into your ear, and it goes into the semicircular canal so that you can hear. This is the smallest bone in a human body. Its size is about, okay, oh, there we go. So we have the 3 ossicles here, and that's called the stapes. So that's this one. It is about 1.5 millimeters by 2.5 millimeters. There is no way that you're going to be able to see that in detail. That's near and dear to me because I have had hearing issues. So this is the current best CT scanner. This is the best picture of that you could take. Very fuzzy, right? This is a picture of that with our CT scanners. It is incredible, right? This is literally like going into Star Trek. This is a picture of a heart. This is the aorta. This is the left ventricle. This is left anterior descending artery. It's traveling between the 2 ventricles, and you could see it in clear detail. It is literally like looking at a cartoon. This is the other one, right coronary artery. Perfect normal person. This is actually the CT angiogram of my child. He's a 15-year-old, very, very athletic person who was having chest discomfort doing this. So Dr. Patel that you heard earlier, we did a whole bunch of tests on him. That was the only thing left to do to make sure that he doesn't have an anomaly short of going into cath lab, right? And picture perfect. It turns out that he's growing too fast, and the bone in the rib cage is not fully mature. So as he travels a lot and jumps and runs, it is beginning to like hurt his chest. So amazing. So I have been an interventional radiologist for longer than I like to know. And with this scanner, I look at the pictures coming out that I have to go and open anatomy books to see what am I looking at. That's all I do, looking at blood vessels everywhere else. And I go, oh my God. So that's the middle meningeal artery. This is looking at ophthalmic artery, the artery that feeds your brain. The resolution, it is incredible. The other advantage of this scanner is we talked about counting all the photons and then just giving an average. But we don't do that anymore with the scanner. We actually can measure different energies. And when you measure different energies, you can also say that this is all noise, electric noise, so we can get rid of it. With other scanners, you can't do that. And also with MRI, you can't do that. And noise is very different. Noise actually grows. It's not zero. It grows not as fast as the signal. So it is extremely important. We eliminate electronic noise, and it makes the pictures much, much sharper without having to, how do I go back? Is anybody here? No. Did they leave? Lost the big pictures. Aaron? Oh, there you go. Previous. So we can get rid of electronic noise. We can say anything that's below this level is noise. Ignore it. It will make the pictures much sharper. You can't do that with the other technology because you don't know which one is noise and which one is the signal. So this over here is a CT of your sinus on the current studies with low dose radiation so that you could see if the sinus, so this is your orbits and these are your sinuses. You're just trying to see if you have sinus disease or not. This is on a photon counting CT with half the radiation, 0.06 millisieverts versus 0.12. You're getting a picture that not only you could see the sinus, but you could see a lot of details. This is your globe. These are the muscles that move. These are your septum. If I want to get the same picture as this here, my radiation will be 1/5 of a regular CT sinus. With this scanner, since we can see different energies and different photons, we can actually measure those energy levels one at a time. So that's what we call spectral. So we can know what signal is coming from calcium. And this is very important, right? Because we can eliminate calcium. Calcium has a lot of blooming artifact, and it's been a major problem for us looking at blood vessels. Anybody that gets over the age of 40, 45, you get a lot of calcium buildup. But it doesn't mean that your artery is closed. It just means that it has calcium. For our population is a lot more. So if you go to Newport Beach or Irvine, maybe about 16% of patients who have way too much calcium for us to be able to see on the old technology. For us is about 30, 35%. On the alpha scanner, we can get rid of the calcium. So this is a patient who's had this CT, and the calcium is what blurs the image and we can't see. With this technology, since we know what that energy is, we can deduct it. We say that this signal is from calcium, not from the vessel. Get rid of it. So now I can actually see what's flowing through versus here where there's too much bloom from the calcium. So this is the same patient after getting rid of the calcium, and the white is the blood vessel flowing through. This is the patient before that. The calcium is keeping away from seeing what you need to see. There is a CT coronary angiogram on a patient. There is calcium right here. When you look at the picture, there's the calcium. And when you take a cross-sectional of that, this is calcium, and this is the part where the blood is flowing. We can remove that. And this is what you see. It's crystal clear that it's not causing any issues. Same process. Same patient. Here, calcium removed, so you can actually see there's plenty of room for this to flow. No reason to stress. The other advantage is that we have much higher resolution. So instead of getting 145 cc's of iodine contrast, I can give you the same images with 55 cc's of contrast. Much faster. Aside from this, I can actually scan you when you get CT with and without contrast. I can skip the without contrast because I can go ahead and eliminate the signal from iodine itself. So I can tell the computer to get rid of that signal. So we can get rid of the beating heart problem. We can get rid of the small structure. We can get rid of the small vessel. Vessels of the heart about 4 millimeters when they're coming out of the heart. And when they go distal to where it matters, they can get to about millimeter and a half. Moving organ, irregular, small vessels. All of these problems are no longer a problem. So these are the patients we couldn't image before. They have too much calcium. This is all calcium. That's not a problem. If you have somebody who is large BMI, very difficult to scan. We can scan up to 500, 550 pounds, no problem. And this is the kicker. How many people do you know who have had a stent in their heart? Once you get a stent, the only way to look to see if the stent is open is if you go to cath lab, except for now. So now we can, and I'll show you some, you can see through the stent. Is my stent open? So we can look at anatomy, we could look at defects. Dr. Sharma was talking about ASD and VSD and patent foramen valley. We can see those things. We could also see them with MR, but that's not a problem. This is a very large patient. For most scanners, it's impossible to look through. You just cannot get enough signal on the other end. This is on photon counting CT. So that's the right coronary artery, crystal clear, that is normal. That's the LAD, crystal clear, that is normal. Save the trip to cath lab. I'm sorry? Yes, everything is with contrast. No contrast, no gain. Is the stent open? How many here have a doubt that the stent is widely open? This is a kissing stent. The two stents are coming together and they're trying to see it, and then there's some narrowing between. This is a patient with a coronary stent, and that's the stent looking through it. Crystal clear, that is open. It's a game changer. There is another stent. This is from our institution. Variant anatomies. So it's actually great to look at this scan. So this was a scan, one of our patients. And the anatomy is that this vessel is supposed to, this is the LAD, left anterior descending, the vessel that can cause a widowmaker. It's supposed to travel here, but it's a variant. It's coming off the right coronary artery, and then it takes a really bad course. It is going through the root of the aorta and the outflow tract for the left ventricle. And as you could see here, it is compressed. So this is one of those things that could actually cause sudden death as the patient exercises. It's dynamite that you didn't know was sitting in your pocket, and all of a sudden the plug is pulled. So we're very good at those now. This may not project well. This is a very complicated patient who's had TAVR before and has had a bypass surgery. And through the bypass surgery, through the bypass, he has a stent, and now he's having symptoms. The question is, okay, where is it coming from? So take the patient to cath lab, do all of those, or do this first, and then take him to cath lab. So I'm gonna move faster. And very clear that, at least to me, that this is the stent, and there's the narrowing after the stent. So you know what the issue is, and you could actually go and address it. So we could do this for screening. You could see that this patient is forming plaque. Now, not all screenings, as we talk about in a minute, if he lets me go a little over time, is to go into the cath lab. The goal is to find the issues before you have to go to the cath lab, so that you could modify behavior and you could modify medical treatment. So the new frontier is actually plaque analysis. What is the plaque? What is the plaque? What is okay plaque and what is bad plaque? The bad plaque is low density plaque. That's the type of plaque that can unroof and cause strokes, can stop the flow to the major vessel. And these are the types of plaque that we can now see on CT very clearly that are the high-risk plaques. They're called positive remodeling because the vessel gets bigger. I'll show you an example of that. This is the low-density plaque that could take off. This is the napkin shape of the plaque. And then if you have spotty calcifications in them. Now, with the AI, we can take this information and we could give it to the computer, and the computer not only tells you that you have the plaque, but it will also analyze to how much of different types of plaque you have. So you don't have to sit there and calculate it. Now, that takes away all of the interperson discrepancies. So you could not only detect what you have, you could also follow up on it, see if it's working. So that low density plaque we were talking about, it's what we call the thin cap fibroadenoma. It's shown that when you have that, your risk of getting a stroke is multiple times over the different types of plaque. So we look at these things as a normal person, as having mild disease, about 30%, as having moderate disease, as having 30 to 90%, and then having severe disease that's greater than 90%. So these guys obviously go to cath lab, but for us is to really take a look at these people and do what needs to be done to make sure that they don't have an event and maybe they don't have to go to cath lab, at least not as early. I want to show you this one. This is very interesting. How many of you here have had calcium score done? Okay, I'm going to tell you that it's useless, and I'll show you why. So, okay, don't do it as a calcium score by itself. It's a form of plaque, but it's a stable plaque. That means that it's not going to give you a heart attack. So this is a 52-year-old male, totally asymptomatic, and his only risk factor is that he works with me. Few years behind me in residency, I brought him here and we've worked together for 17, 18 years. Totally healthy, no issues at all. So these numbers are turned around, but in 2023, he had a calcium score, and the calcium score was, that's 23, is supposed to be here, 56. Not bad, you know, for a 52-year-old. The following year, so when the scanner came in, I am all over him to go get the scan done. Get the scan done. So finally, he took his mother-in-law to have the scan done, and he decided, with persuasions from his wife and my wife, to get the scan done. So had he stopped at a calcium score, you would have seen that it's just a little bit higher than it was before. Most people would say, oh, it's expected with age. But that's not where we stop. Oh, this is his CT coronary angiogram. That was done a couple of seconds after the calcium score was obtained. So again, the white is where the blood is flowing, and the dark is the plaque. And as you're coming through, everybody here, I'm sure, can understand that this is getting narrow, right? And this is the vessel again. You see the remodeling. You see that the vessel, that's a normal side of the vessel right here. You can see the vessel is expanding, it's inflamed, and it has a lot of soft plaque. And the only thing that's left here is this little bit of flow going through it. It's all good until it's not good, right? So he ended up going to cath lab, and he ended up having stent placed, and he could have had a major event. So this is what we give to our doctors, and I'm sorry that it doesn't project well. But we give them different types of plaque and how high it is and the degree of stenosis. And now we do what's called FFR that shows you which one has a higher risk of being hemodynamically significant. So he had hemodynamically significant in his left main and a couple of smaller vessels, and he had them stented. And I brought him back a week or so later to get a CTA of his neck because he had a lot of plaque going up. And we caught this at the edge. So this is after his stent was placed. Same vessel. So not only we can see your disease, we could also follow up on your disease. And if you've had the stent, we could see if your stent is still open. Calcium does not matter. So the other thing that is done in the cath lab, it's called FFR, or fractional flow reserve. That shows how bad is this lesion is. So if there's no drop in the blood pressure, that value is 1. And if it's less than 1, that means that it's significant. It's obstructing the flow. It's AI driven. It takes fluid dynamics and it gives out some numbers. So there is a patient who had it, and this came up. There's a lesion right here. And when you measure it here, it's 0.94, and when you go distal to it, it's 0.63. That is significant. This patient needs to go to cath lab. This is what we saw on a CT angiogram. You could see the narrowing, you can see the plaque, and unfortunately, it's not projecting well. Same thing showed up in a cath lab, and it was treated. So the new diagram for this is, so CT angiogram for coronary is now level 1, non-invasive diagnostic study for coronary artery disease. So let's go back again. Number one, non-invasive, meaning that they don't have to put a catheter in you. Looking at coronary artery disease, you will get anatomy, you will get function, you get plaque, and you get variance. So it's done. If the disease is less than 40%, medical treatment. If the disease is 40% to 70%, 70 to 90%, we'll measure the FFR. If that FFR happens to be positive, less than 0.8, your cardiologist will determine whether it's real. They could do another study to confirm, or if it's significant to take the cath lab. But if the stenosis is greater than 90%, like it was with my work partner, you would go to the cath lab. So it's not only amazing for diagnosis, but it's also amazing for follow-up. And it's the first time, the only time that we can actually see through stents. And calcium does not matter. That's why I brought it to the desert, because of our population. I do not have a patient that I don't look at going, oh my God, you're too young, that doesn't have a lot of calcium, hasn't had a stent. And now I'm getting to be much younger than some of those, much older than some of those patients. So it's important for me to have it. So just to summarize, in 2006, 2010, we hit the FFR, and now we not only can look at the FFR, but we can also look at the physiology. We can tell you what is important, and we can look at the same thing over time to tell you how you have progressed, whether you have bad plaque, okay plaque, and how you changed by doing your treatments. It's critical to know that it's the most sensitive and specific for coronary artery disease, as compared with any test that's out there, other than when they do a coronary angiogram. But even when you get a coronary angiogram, you don't know what type of plaque you have. You know you have plaque, but you don't know how much of it is calcified versus non-calcified, and from the non-calcified, which one of them is the bad plaque, which is the low-density non-calcified plaque. So here, normal person going through and then taken to all the way to the person who should have severe change in behavior and medical treatment. So in conclusion, CT coronary angiogram, photon counting CT, it is a different world out there now. This is only for the coronaries. You can imagine for the entire body is a different story. There's only one vendor who makes it, and everybody else is scrambling because they were climbing up wrong trees. It is incredible. I thought that it was worth the money. And after 21 years, when I first saw this one, I was very happy with my career. I thought that that's great. Now it's time to start thinking about retiring. Ever since I've seen this, I feel like I am 25, 26, 30 years old, and it is incredible. I mean, I cannot tell you how jubilous I am whenever I look at it. It's like I look at cartoons when I'm looking at CT images. And it is amazing. You know, we want to catch the bullet before it leaves the gun. And that's the issue. That's the next frontier. We not only want to live long, we want to live long, live better. It's improved patient care, and the detailed visualization is amazing. And again, American College of Cardiology, behind Europe. In Europe, it was the #1 several years ago, but it was just adopted to be the level that has to be higher than anything else. And I hope you take advantage of it. We have it in our community, and it's available for you. Any questions? We always would like to have a referring physician. If there is a good reason for it, it's covered by your insurance. If people want to pay for it, it also is available. But we always want to have a referring physician because we don't want to find things and then not to be able to treat it. And the nice thing about having it done at Eisenhower and Eisenhower Imaging Center is that we are connected to everybody. Anybody that you go to can see our images. They're available 24/7, and it's their own cardiologist, and we're just a phone call away.
Tell me the price or the price range for.
So it's covered by Medicare. and it depends on what they do. So the most expensive part of this is that AI that goes out. So if comes through your insurance, it's covered. If it's not, the CT part of it is about $400. And if you want to have the full package with the AI, I believe it's like $1,200. And there are times that they do specials, but it's the AI that is very expensive. Now, not everybody has to have it, but I think it's important, especially if it's not dead normal. But it is covered by insurance now, and Medicare covers it. And anytime Medicare covers something, you should know that it is good. And when Medicare doesn't cover it, that means that it's not prime time yet. Yeah. Yes, if it's appropriate reasoning. So if there is significant over 40% and factors that has to do with making it appropriate, yes, they do. And we don't charge for it if they say no to it afterwards. It's done as a part of it, and everybody else just lets it go. So it's a good thing. Go ahead. Yeah, so it's interesting you brought this up. So there are two companies that do the FFR. So one of them is the HeartFlow, and the advantage of HeartFlow, and we don't use them, we use Clearly because there are other things that we liked about them. It not only tells you that it's less than 0.8, it tells you how much less than 0.8 it is. So 0.6, 0.4, I've seen up to 0.3. Clearly will only tell you if it's less than 0.8. Have the cardiologist, because we can tell you it's there and it's real, because it's unlike the stress test and other things. There could be other things that is going on or artifact, but a cardiologist can look at your history, can look at what you have, and they can correlate it with the other exams. Again, the problem is not the ones that are absolutely normal or the ones that are clearly more than 90% with a positive FFR. It's the ones in the middle, right? And it's the ones in the middle that you definitely want to have your cardiologist, because with those, no matter what, even if you go to the cath lab, you want to change behavior, and it's how aggressive they're going to be afterwards, and then how they follow you up. And that's another advantage of this exam, is that after you've had your test and your behavior, you could actually go back and quantitatively look at what change has taken place by doing what is being done. So those decisions are made by your cardiologist, right? And if you're in a hospital, so first of all, we don't have this in a hospital setting, but that's a great question because we are getting there. So after I brought this in, it's a joint venture. Now the hospital is convinced that they need to have this. It takes longer for the hospitals to get it because of the laws and regulations and OSHPAT, but we are actually working on bringing it to Eisenhower. And it's amazing because it's another set of information that you're going to get the CT chest anyways. Have this so you could look and see if your heart is okay. And you will get like 3 signals: green, red, or yellow, right? So if you're red, if you're green, you're okay, and the yellow is in between. But in the hospital, they have other ways of looking at it to see if you're actually acute. They look at enzymes to see if there's events with your heart. Now, once you're done with that, you go as an outpatient, and they could look at other things that you have, including this CT. No. It's in the Eisenhower Imaging Center. It's one of a kind. It's a unicorn, and currently is sitting in the building we have in La Quinta, in the Arduous building. Over the next year, we are opening a new imaging center on the corner of Country Club and 111. And at that center, we're actually going to move this, plus bring a sister, because these things need to be running very efficiently, and being able to do mass numbers, they're so expensive to keep them. So we're going to have 2 of those. We're upgrading to a brand new PET CT scanner that can do 40 PETs a day instead of 16 at 110% capacity. So we realized that the population has changed and we have grown leaps and bounds. So we are working very hard to get there. And we will be there, hopefully next year. Hospital will be about 2 years, but we're working on the plans. Yes. So that's a good question. Today, I was just talking about this. So you could imagine the level of my excitement, because we cover from head to toe. Oh yeah, that's unfortunately I do too. So and you could see a lot of stuff having to do with the ears if you have autosclerosis and other things. But unfortunately, Meniere is a different animal. But this is great because it's for early cancer recurrence, for early cancer detection. Again, the resolution and the fact that it's spectral, meaning that I could see different chemicals and I could see the different enhancements so much more clearly. That's why I'm buying two, because I think over the next 6 months or a year, I'm not going to be using my other scanners for anything other than routine. So the first timers, we like them to be scanned on this to make sure we don't have anything. Yeah, you can ask your physician to ask for it. For most parts, you don't really need to, right? One of the advantages of this is that, you could have patient that would get a CT of your hip, and gosh, the fracture is not bad enough to see. It's just very subtle, minimal, like a hairline fracture. So you could miss it on the CT. You could get it on an MRI. You could see it on an MRI, but on this scanner, you could actually see it because of the fact that not only has more detail, but you could also see the signals from water. So you can see that there's blood and there's edema. So that's why I can't wipe the smile off my face. Okay. Thank you. Thank you. Hope you enjoyed it.